Hello, welcome to today's video where we're going to be looking at intestinal ischemia. Since we are talking about ischemia, it would make sense that we first talk about the blood supply to the entire gut. That's going to be including the small intestine and the bowel. So the first major artery that's involved is going to be the superior mesenteric artery, and that's the diagram that I have drawn below shows the actual superior mesenteric artery. So it goes all the way, it comes out of the aorta and it goes all the way down. And one of the first branch that it gives off is going to be the middle colic artery. And so the middle colic artery goes up, it branches off, and you can see it goes up to the transverse colon. And then you have the right colic artery. And the right colic artery goes, as you can see, it supplies the ascending colon, and then it anastamoses with the middle colic artery right here. And then it's going to continue on the other side to the intestines. We have the jejunal arteries. And so, as you can see, all of these come out here, and then they anastomose with each other, and then you get the entire small intestine there taken care of. So what does it actually supply? It supplies all of these small intestines except for the duodenum. And with regards to the large intestine, it supplies the cecum, the ascending colon, and it also supplies the proximal transverse colon. So I've kind of highlighted in blue the entire part of the colon that it supplies. So the other major artery that's involved is going to be the inferior mesenteric artery. And so what you just need to remember is together the superior mesenteric artery and the inferior mesenteric artery, both of them combined will supply blood flow to the entire small intestines and large intestine, with the exception of the duodenum. So that should make it very easy to remember this. What is the first artery that comes off of the inferior intestine is going to be the left colic, which is going to go into as you can see, the descending tract. And as you can see, as the left colic goes up, it anastomoses with the middle colic. And then you also have the sigmoid arteries, and that goes down into the hemorrhoidal arteries. So that's your basic blood supply of the inferior mesenteric artery. And what does it cover? The distal transverse colon, the descending colon, the sigmoid colon, and even the rectum. So pretty much the remaining part of the colon is covered by the inferior mesenteric artery. So now, since we've talked about the arterial blood flow, let's talk about the venous side. And the venous side is all going to be portal venous drainage. So as you can see, all of the veins, so you have veins coming here from the rectum all the way to the descending colon. It goes into the portal system. And also you can see, these go into the inferior mesenteric artery, which goes into the portal system, portal vein, which then goes into the liver. And then you also have here the ascending colon and the rest of the intestines all going into the superior mesenteric vein, draining into the portal vein. This entire system, so highlighted there, is what gives the portal vein its blood flow. And this pretty much parallels the arterial circulation. So wherever the arterial circulation is, this just goes right alongside of it. What we can also talk about real quickly is going to be some of the watershed areas which are prone to ischemia during hypotension. And these are areas either at anastomosis or they have a small amount of blood flow. The first is going to be in the splenic flexure right here in the top right-hand or left-hand side. This is a watershed area. This is called Griffith's Point. And so it's a watershed area, meaning if there's ever any hypotension or loss of blood, it's one of the first areas that experiences ischemia. The next is going to be Sudic's Point, which is here in the recto-sigmoid junction. And so that's another area just like the Griffith's Point. And here in the ascending colon, this is only present in 15% of people that are missing the artery of Drummond. And so the individuals who might be missing this artery might actually experience ischemia here. And so this could be a watershed marker here as well. But again, only 50% of the population have it. So now we've talked about the anatomy, let's talk about the definition of intestinal ischemia. So this is going to be, simply put, decreased blood flow to the bowel. And this can be, arise from three reasons. Either it could be an arterial occlusion, it could be a venous occlusion, or there could be some type of vasospasm, in particular the arterial. And with arterial occlusion, there's two different possible mechanisms. Either an emboli or a thrombus causes the occlusion, and then you have decreased blood flow. And so what you would imagine is generally arterial is generally more serious, causes symptoms much quicker than venous, because venous it needs to build up and then causes occlusion, but arterial occlusion, much quicker you get ischemia. So let's talk about the different names, or the different types. The first thing is you could differentiate them based on location. So when you're basing them on location, we split it into small intestine or large intestine. And so small intestine is called mesenteric ischemia, and large intestine is called colonic ischemia. And with mesenteric ischemia, you also include the liver, the spleen, and the kidneys as well. So these are oftentimes included with mesenteric ischemia, and again, because they get the same sort of blood flow from the celiac trunk though. Now, let's talk about some of the physiology that goes into the normal bowel behavior, how the blood is distributed, and that way you can understand the abnormal much easier. First of all, the bowel gets anywhere from 10 to 35% of the blood flow, and this depends on whether it's the feeding state or the fasting state. So obviously, if you're in the feeding state, this would be much closer to 35%, and if you're in the fasting state, it'd probably be closer to 10%. Now, the bowel does have a high vasculature, but it doesn't use much oxygen, so there's low oxygen use. And so this means that there's more oxygen goes to the liver via the portal system, because remember, the venous drainage goes all the way to the portal vein. And so therefore, whenever there is blood flow lost, it requires about 50% of the blood flow must be compromised before you start to experience any problems. So your gut, in other words, can handle a loss of blood flow fairly easily. And this makes sense because the blood flow isn't necessarily to deliver oxygen, it's actually to absorb the nutrients from the intestine. So the fact that it, if you cut the blood flow even up to 50%, you still might be okay. And so this is the reason why whenever there's hypotension, so during hypotension, the blood flow goes away from the gut and it goes towards the brain and heart. And so there's many reasons for this. First of all, like we mentioned, it not necessarily have a high blood flow because of the oxygen requirement, but it's more because of nutrient absorption. And also, you can, if you lose a little bit of bowel, that's probably not as bad as losing brain. So, your body tries to preserve brain as much as possible. And so what are, different mechanisms that can do this? This can either do it through the sympathetic nervous system, the renin-aldosterone-angiotensin mechanism, or vasopressin, which is secreted by the posterior pituitary. So now that we've talked about the normal, let's talk about the abnormal pathology that's related to it. So what happens in response to ischemia, you get two types of injuries. First is going to be injury due to the hypoxia of not having oxygen, and then once you have reperfusion, that reperfusion can then cause more injury. So these are your two mechanisms of injury that you need to keep in mind. However, the gut can compensate up to 75% drop for about 72 hours. And this again is because it can just start uptaking more oxygen with the low amount of blood that it currently has. However, the colon is more vulnerable to this drop because of the fact that it has lower perfusion, hyperperfusion, and it has less blood flow coming to it, so any sudden drop in blood flow will affect it. So that's something to keep in mind, just the fact that the colon is more susceptible to hypoperfusion than the small intestines. Now, what I'm going to do now is we're going to talk about clinical findings in general, because there are different types of, I guess you can say different types of ischemia depending on the etiology, and they all have kind of slight variations in clinical appearance. However, I'm not going to just go over a general finding that you would find in most of them, and there are some exceptions to this. So first of all, in the acute, if there's an acute sudden pain, it's generally described as pain out of proportion to physical findings. So the patient will come in, talking about excruciating pain, but you touch the abdomen, you're looking around, it doesn't seem to be that tender, there doesn't seem to be any guarding or anything like that. So pain out of proportion to physical findings is a big signal that you might be dealing with ischemia. The other is going to be in chronic state. So generally what happens in a chronic state is the bowel is able to form collaterals or is able to compensate somehow for the loss of blood flow to the bowel, and so it's going to lead to a symptom called intestinal angina. So this is a kind of a colloquial term, and what happens here is they have pain after eating, and so then every time they eat there's pain, so then they have associated weight loss. And you also have peritoneal findings, which can be, these peritoneal findings are generally late findings, and so just in case you've forgotten or you haven't learned, peritoneal findings is when you have guarding. Guarding is whenever you touch the abdomen, they stiffen up, and rigidity. So again, you touch the abdomen and firm. And finally, you can also have distension and decreased bowel sounds, and this generally means that it's transmural. So it's pretty much gotten through the whole entire length of the bowel. And finally, you can even have feculent breath. And so the final stage of all of this is going to be shock and dehydration. And this generally, if a patient gets that means they're generally deteriorating. And so you need to act fast, otherwise they will expire. So let's move on. So this is general clinical stuff. Again, we're going to go into more detail based on the different types, but generally this is, symptoms you can find. Let's talk about investigations. So we'll talk about general investigations that you might want to do. We'll begin with laboratory. You might find leukocytosis, not always, but that is there oftentimes. Hemoconcentration, as they start to lose blood flow, it can start to lead to that. And you can get metabolic acidosis. And just a quick thing, metabolic acidosis plus pain, whenever you have these two together, then you have to assume it's mesenteric ischemia until otherwise proven. So you must rule out mesenteric ischemia with those two symptoms together. So you can see how common this is with this condition. Lactate is another signal, and if it's high and you've been able to rule out shock, diabetic ketoacidosis, or renal or hepatic failure, then that becomes even more specific for ischemia. So definitely lactate is some marker you want to watch out for. Also, high amylase does occur in about 50%, phosphate in about 80%, and you can even have high D-dimer, showing the thrombi formation. What sort of imaging would you want to do? You can do an X-ray. That's one. CT scan as well is another good idea. And depending on the underlying etiology, you might get different images, and we'll talk about that when we talk about each one specifically. Mesenteric angiography, so that allows you to see the actual arteries and veins as they go through the mesentery or the bowel. So you can we'll talk about that when we talk about individual etiologies. Magnetic resonance arteriography or CT angiography can definitely be helpful as well. And finally, colonoscopy if there's any colonic ischemia. So those are your general imaging modalities available for this condition. Now, general management, we're going to discuss here real quick. And again, as we talk about each individual one, there'll be more to say about, kind of fine-tuning it. Number one is fluid and electrolytes. So remember, this is the number one thing that you're thinking of. Then you might want to think about doing GIT decompression, generally with an NG tube. You also want to consider anticoagulants if that's the underlying cause. And antibiotic also might be a good idea, not necessarily because it's, you're worried about an infection, but I mean there is an infection going on, but you just don't want to transplant any bacteria into the wrong area. And finally, if all of this doesn't work, abdominal exploration is your big way to go. And so, if there's any signs of peritonitis, infarction, or perforation, then you definitely want to do this as a first line. Okay, so now that we've kind of talked about general features, what we'll do now is we'll talk about, first we'll talk about mesenteric ischemia, and then later we're going to go ahead and we're going to talk about colonic ischemia. So there's 4 types of mesenteric ischemia, either an arterial embolism, or it could be due to an arterial thrombus, a venous thrombus, or a non-occlusive mesenteric ischemia, or they call it NOMI. So arterial embolism is due to a dislodged embolism, usually from the left atrium, left ventricle, or a valve. So something from the left side of the heart dislodging and going into the mesenteric artery. Arterial thrombus is usually due to an atherosclerotic plaque. A venous thrombus is due to some type of high coagulable state. And non-occlusive mesenteric ischemia is due to some sort of vasoconstriction of the arterial artery or the arterial system. So what we'll do first is we'll look at arterial embolism. So the arterial embolism is more common in the superior mesenteric artery than the inferior mesenteric artery, and that's because the superior mesenteric artery is wider and it has a narrow angle, kind of reminiscent of the fact that in your right lung you tend to get more foreign objects than in your left lung. So kind of reminiscent of that. And usually it's 3 to 10 centimeters from the origin of the superior mesenteric artery, and the part of the bowel that's affected is generally the mid segment of the jejunum. So that's generally where you get the most of the necrosis. And in 20% of cases, you might have multiple emboli, so that's something to keep in mind, that there might be other parts of the bowel affected. So how do you treat it? Treatment, this is much more serious, so we definitely need to just go in and do surgical laparotomy. And so what they'll do is they'll do what's called an embolectomy, where they actually remove the part of the bowel which has the emboli, or sorry, not the bowel, but to remove the part of the artery that has emboli, and then re-anastomose the rest. So that's what they do there. And then you're going to want to examine the rest of the bowel for ischemia, and if there's any ischemic areas you want to resect that, and that's true for any of the causes. Now, sometimes you can do just thrombolytic therapy, and this can only be done if there was an arteriography done within 8 hours of the onset of pain. So if you're able to get to the patient really quickly, then maybe you can try thrombolytic surgery, and there could be no clinical evidence of peritonitis. So if there's any guarding rigidity, distension, or decreased bowel sounds, then you cannot do thrombolytic therapy. You need to go into surgery. And so what you would do is, in this case, you would give them, say if they did qualify, you give them thrombolytics, and then you would wait 4 hours, and if they didn't improve 4 hours, then you just go on to surgery again, and you go ahead and do an embolectomy. Long term, we want to give warfarin to prevent another emboli from forming. Next we're going to talk about is the arterial thrombus, and this is going to be, okay, sorry, let me remove that. So atherosclerotic plaque, when would you think about it, is whenever there is a history of abdominal trauma or infection. So this would, so atherosclerotic plaque, any history of abdominal trauma or infection, you want to think of an arterial thrombus. And this generally affects the superior mesenteric artery as well as the celiac artery, and again, generally it's going to be at the origin of those arteries. Treatments, what you want to do is you want to do revascularization, and so this is, so revascularization you want to do, and thrombectomy. You can also try doing that, where you actually remove the thrombi, and then there's also, after you're done with that, you do need to resect any non-viable segments. And then in this case, we generally give aspirin for long-term control to prevent that plaque again from thrombosing. So after arterial thrombus, we're going to now talk about venous thrombus. This is the one that Virchow's triad and what Virchow's triad is, the factors that can lead to having a thrombus form in the venous system. So there's 3 factors that can lead to this: either stagnation of blood flow, some type of vascular injury, and a hypercoagulable state. So the area of bowel that's affected is, number 1, it affects the ileum first, After that, you can go up a little bit into the jejunum. Then we have the colon, and finally the duodenum gets affected. So as you probably realize, this is the first time we mentioned the duodenum. So kind of need to remember that duodenum is, if the duodenum is infarcted, it's most likely a venous thrombus compared to other things. So what is the pathology? Well, you generally have a vein occlusion. And so once you have a vein occlusion, this leads to increased resistance. And so then this will lead to an efflux of fluid and edema of the wall. And of course, eventually this edema will get so much that it can include the arterial system and lead to ischemia. So what are risk factors? We'll talk about that now. So risk factors, up to 20 to 40% have a history of DVT. So you can definitely say a patient with DVT is generally at risk for other thrombi, including the mesenteric and also others as well. The next would be any type of abdominal mass. And so this can be either a tumor or a pseudocyst. And so these can actually physically push on the veins and then cause occlusion. Next would be inflammations such as pancreatitis or even diverticulitis. And these inflammations tend to release prothrombogenic cytokines, and that can lead to hypercoagulability. Myeloproliferative state, that increases your platelets, and that can definitely cause it. Portal hypertension causes backflow, and that can be one cause. Acquired thrombophilia, and so this can be either a female taking oral contraceptive pills or a malignancy of a patient that can cause thrombophilia, and even inherited thrombophilia, such as factor V latent, and there's obviously other ones. And finally, inflammatory bowel disease. Again, that's kind of like an inflammation, so releases cytokines that can be prothrombogenic. So how do these patients present? There's three types of presentations. First is going to be acute. You also have subacute, and you also have chronic. Acute is going to be the same as we mentioned earlier, with the pain out of proportion to physical findings. Subacute is going to be more assiduous. The patient will have pain for several days, and then they'll come in. And then chronic can generally be asymptomatic, and it can even be an incidental finding. And this is generally related to a complication of portal hypertension. So keep in mind, portal hypertension, when it does cause ischemia, it's chronic ischemia, and so it'll take a long time before symptoms show up. There are some investigations which are specific to venous thrombus. First is going to be magnetic resonance venography, which will actually highlight a lot of the veins for you. Then we also have X-ray. Now the X-ray here is going to be different than the other causes. First of all, 25% can end up being just normal X-rays, so you can't necessarily rule it out. But they will also have distended bowel, and they can also have pneumatosis intestinalis, which is air in the intestines. So here's an X-ray here, and what you can see is the bowel wall is distended there. So that's a highly distended bowel wall, and you can see all the air that's also filling up. So you have air in all this area, and you can see it's very bloated and distended bowel all through here. So that's going to be a classic finding. But again, 25% might even be normal, depending on how early you caught it and what the pathology is like. So next, you could try to do CT. Let's see if I get this going. Okay, there you go. So we can do CT, and this could be with oral or IV contrast. And what you'll see is some filling defects that the contrast can't get to. So finally, you can do a Doppler ultrasound. And so Doppler ultrasound can show the speed of blood flow. And so in Doppler ultrasound, you might see an increased velocity because of the occlusion. And so what kind of treatment would you do? Here, you can try a conservative treatment where you just observe, give IV fluids. So you can observe, give IV fluids and electrolytes. And oftentimes, it's also necessary to do bowel decompression because of the distended bowel, so you might want to do that. And on top of that, you can give antibiotics, again, give it to decrease translocation, and maybe some anticoagulants, such as low molecular weight heparin. So this is generally done, and the low molecular weight heparin you might want to give for 3 to 6 months even afterwards to prevent the formation of another thrombus. So this is generally conservative management. However, if you do have one of the chronic cases, you might want to go in and do endoscopically control some of the ectopic varices. And so an ectopic varices is kind of like an esophageal varice where you have these vessels which are protruding, and these can rupture at any moment. So if it is a chronic case, you might want to take an endoscope, go in, try to find these ectopic varices, and then plug them up, with either sclerotherapy or something else. And finally, you would need to do surgery, especially if there's any evidence of necrosis and perforation. And also there's something done which is called the second look surgery. And so what second look surgery is, sometimes you do up to 24 to 48 hours after. You go back in, you look, and sometimes you might have missed an area of ischemia, or some area of ischemia came up later due to reperfusion injury, and so you need to remove that bowel. So sometimes, actually for most of these, you do need to do a second look therapy. So finally we go on to the non-occlusive mesenteric ischemia. So the first thing we need to think about is why this occurs. So you have to remember that the body will always maintain the cerebral and cardiac blood flow at the expense of the bowel. And so it does this by vasoconstriction of the bowel vessels and vasodilation of the cerebral vessels and cardiac vessels. And so this vasoconstriction of the bowel is caused primarily by vasopressin and angiotensin. So these are the two hormones which can cause this. So the risk factors would be anything that would lead your body to be in a hypoperfused state. So of course you should be thinking heart failure and shock, aortic insufficiency, because the whole body won't get enough blood flow, any arrhythmia, which causes especially ventricular, cocaine or ergotamine can also cause severe contraction, and other vasoconstrictive drugs can also cause it, dialysis as well, and cardiopulmonary bypass. These are general conditions that can lead to non-occlusive mesenteric ischemia. And again, all of these are related to hypoperfusion of the vessels that affects the entire body. Clinically, generally patients who have this type of mesenteric ischemia are very, very sick, and the symptoms of mesenteric ischemia are generally overshadowed by the illness that they have. So, you're not going to have too much findings, and 75% do have abdominal pain, so even 25% might not even have abdominal pain, but they have ischemia. So again, it's going to be very difficult to look for guarding or rigidity when the blood pressure is low and they're tachycardic. So you're not going to be focusing too much on clinical findings when this occurs. But of course, it is important as a secondary to diagnose and treat the mesenteric ischemia. What kind of investigations would we like to run here? So let me get situated. One second. Okay, there you go. Investigations you want to do. X-ray and CT, you're not going to have any findings which are specific to mesenteric ischemia, but it does help rule out other causes. So again, you're not looking for mesenteric ischemia, but you're looking to rule out other causes of abdominal pain that may be present. You can also try arteriography. And so arteriography shows up all the arteries, and what you'll see is spasm of the mesenteric arteries. So mesenteric arteries. Okay, so here's a X-ray here. Let me just pop that up. Okay, so as you can see, these arteries here, they're very light, and you can see they're very thin, and they don't really show up too well. And so these actually are supposed to be much larger. And so, and you even have the renal artery there, which is also much thinner than it should be. So that's kind of a sign of non-occlusive mesenteric ischemia. How would you treat it? Well, first you want to treat the underlying cause. You want to treat the shock or whatever might be causing it. And you also, one of the things when the patient is in shock, you want to use vasoconstrictors to help raise the BP. But you do need to keep in mind that when you use vasoconstrictors, that can lead to mesenteric ischemia. So you want to avoid vasoconstrictors. But of course, sometimes you have to use it because of the low BP. So if you do have to use it, the only ones you should use, or the only exceptions to, are dobutamine, low-dose dopamine, and milrinone. So these can be used, and this is because they have a low effect on the splanchnic vasculature, and so these are the three that can help you solve the problem of low BP and still not cause a new problem of mesenteric ischemia. So what you also can do is you can do a vasodilator of infusion, and so what this means is you actually go in and you inject some type of vasodilator into the superior mesenteric. And the two ones that I use is papaverine, prostaglandin, and nitroglycerin. So there's actually three. And finally, you may need to do surgery, and surgery, especially if there's any evidence of infarct or perforation. So we've talked about mesenteric ischemia. Now what we'll do is we'll change our focus to colonic ischemia. So colonic ischemia, again, is going to be ischemia that affects the large bowel instead of the small bowel. This is more frequent in the elderly, and again, the different types are also here with arterial occlusion, venous occlusion, and NOMI. The most common one with colonic ischemia is the non-occlusive mesenteric ischemia, which is up to 95% of the cases. And that's because it's more sensitive to hypoperfusion than the rest of the bowel because it has a lower blood flow, like we mentioned earlier. Then second is going to be emboli or thrombosis, and the final common cause is going to be venous thrombosis. So these are, again, very similar to mesenteric ischemia. However, they all present similar, so there's no need to go into the different types one by one. What are some risk factors? Again, anything that can cause hypoperfusion. So any type of abdominal aortic aneurysm or aortic iliac surgery for those can cause it, and that's just because oftentimes when they do these surgeries, they kind of cut off the aorta, or they'll clamp the aorta, and that can lead to hyperperfusion for a prolonged period. Cardiopulmonary bypass, again, you're cutting off the flow for quite a long time. Myocardial ischemia, or infarction, hemodialysis, again, even the acquired and inherited thrombophilia is going to be other ones. Certain drugs are also going to be on the list that cause hypotension, such as diuretics, NSAIDs, and it's a pretty long list, so I can't go into all of them, but there's a few drugs out there. And also extreme exercise is also another possible cause, so that's something to keep in mind with athletes. So clinically, what do you have? So it's different symptoms depending on whether it's acute or it's chronic. So we have different symptoms. And the first thing that you should realize is generally going to be less severe than mesenteric ischemia. However, they do tend to have increased tenderness. So that's just a quick way to differentiate mesenteric ischemia from colonic ischemia. So in the acute phase, you have a mild abdominal pain, and it is tender. Whereas, and you also might have some rectal bleeding and diarrhea, and it might even be to the level of hematochezia. Hematochezia just means outright blood coming from your rectum, from the rectum. In chronic, however, there's going to be recurrent bacteremia and sepsis. So the patient might not be feeling pain, but because the tissue is getting necrotic, it's going to be a site of bacterial seeding. There may also be protein losing enteropathy as the the inner layer of the colon gets sloughed off, and they'll have this recurrent type of abdominal pain, which kind of never goes away. So those are the things you want to think of. Now, in the acute, chronic. This is a very, very important point that I just wrote down here. It's oftentimes misdiagnosed as IBD, and it's very, very similar to IBD. So this kind of a quick way to remember it, the fact that it's commonly misdiagnosed as IBD is probably because it commonly presents as IBD with the recurrent abdominal pain and blood. So in the acute, there are phases that it goes through. The first phase is the hyperactive phase, and so this is going to be initiated with severe abdominal pain and the bloody diarrhea. So that's kind of starts the whole process off. After that, you go into the paralytic phase, and so in the paralytic phase, what you're looking at is There's less pain, but there's more tenderness. And there's also a high amount of distension and a decreased bowel sound, and that's why it's called paralytic, because the bowel isn't contracting anymore, so that's where you got distension and your bowel sounds. And then finally, you're going to get the shock phase, which is this phase you definitely don't want to be in, and that's when they get sudden loss of fluids, and they pretty much go into shock, and this generally means that there's gangrenous mucosa following. So now let's talk about the chronic. So we said it was misdiagnosed as IBD. Well, how do you differentiate it? Well, the biggest point is that it doesn't respond to immunosuppressants. So if it's IBD, it will respond to immunosuppressants, but since it's not IBD, it's not going to respond to that. Also, there's a specific type called sclerotic colonic ischemia, and this is basically due to the veins having scarring, fibrous scarring, and it's generally found in the right colon. And so when you have this fibrous scarring of the veins, it eventually occludes until you don't have blood flow, and that can lead to chronic ischemia of the colon. It's most common in the right colon, and in X-ray it shows up as linear calcifications, and on CT it shows as mesenteric venous calcifications. So if you see calcifications in the right colon, you might want to be thinking about this, especially if they have recurrent abdominal pain or something like that. And finally, with regards to phlebosclerosis, it resolves spontaneously, so there's no really need to treat it too much. So how do you diagnose colonic ischemia? First thing that you want to look for is any history of the risk factors that we mentioned earlier. And then you're going to want to do a colonoscopy, which will show some area of necrosis and edema. Or you want to do an arteriography, and so this will show, and you only want to do this if the clinical examination shows ischemia, but the endoscopy is not revealing anything. So, something to do if you're kind of conflicted, but the results aren't showing what you would expect. So finally, treatment. First step in treatment, especially if it doesn't seem too bad, is going to be primarily supportive. And this is regarding IV fluids, nasogastric tube for decompression. You also might want to give antibiotics, especially broad spectrum, again to prevent that translocation. And finally, abdominal exploration. And this is done when you have full thickness necrosis on colonoscopy, or it's not, if you have a situation where it's not responding to supportive care. So that wraps up the topic. Hope you learned a lot, and I'll see you in the next video. Thanks.